everyone. I welcome you all again to the Retina series lecture anchored by the Kunle Hassan Eye Foundation Academy. Today we'll be looking at the lecture on interpretation of retina, optical coherence tomography angiography, which is OCT Angio. And our speaker today is Dr. Olufemi Odenrilo. My name is Frances, and I work with the Eye Foundation Hospital and the Kunle Hassan Eye Foundation Academy. This is briefly how the program will go. We'll have a brief introduction and welcome, which is what I'm doing now. A presentation from the speaker from 8:10 to 8:45 a.m. Interactive Q&A session from 8:45 to 8:55, and then the closing remarks. Just a brief house rules. We'd like everyone who is not speaking to have their cameras turned off and only the speaker to have his camera turned on. This is because the lecture is recorded and it affects the recording when we have multiple cameras up. If you have any questions, you can type your questions in the chat box. We ask that you please keep your mic muted throughout the lecture until the Q&A session. You can either indicate by raising your hand up or by chatting in the comment section with your questions. So I'll quickly move on to a brief introduction about the Kunle Hassan Eye Foundation Academy. The Kunle Hassan Eye Foundation Academy is part of the Eye Foundation Eye Care System. It is the arm that takes care of training, oral ophthalmology related training, ophthalmic nurses, optometrists, nurse and middle-level ophthalmic practitioners. I'll quickly do a summary of our lecturer today, Dr. Olufemi Odenrilo, who is the President and Director for Clinical Research, Eye Foundation, Kunle Hassan Eye Foundation Academy, is also the past chairman of the Retina Society of Nigeria. He started his career from when he did his residency at the Eye Foundation Hospital in 1997. During his residency, he trained his clinical attachment at the Tenet Institute of Ophthalmology in Scotland, Olabisi Onabanjo University Teaching Hospital in Shagamu, and a commissioner of ophthalmologist posting at Ayo Bello Eye Hospital in Ilorin. He became a fellow of the Royal College of Surgeons of Edinburgh in 2002 and also obtained his diploma in ophthalmology from the Royal College of Ophthalmologists of London in the same year. He is a fellow of the West African College of Surgeons and has a master's in clinical research from the University of Liverpool in the United Kingdom. Dr. Odenrilo completed his subspecialty training in vitreoretinal surgery in Eye Foundation Hospital under the tutelage of Dr. Adekunle Hassan in 2004. He is a recipient of the Ava Avo Host Research Award in USA in 2010 and has many observatory and clinical achievements in different countries. He's the current medical director of Eye Foundation Hospital. He's very proficient in various procedures and surgeries. Some of his significant achievements is that he has presented many scientific papers in many international conferences. He is the present ophthalmology editor for the African Vision and Eye Health Journal. He's a member of the American Academy of Ophthalmology. He is the Secretary of the Retina Society of Nigeria. He was the Secretary of the Retina Society of Nigeria from 2004 to 2014. He's a founding member of the same society, and he's a member ophthalmologist of Society of Ophthalmology in Nigeria. Thank you. And today we'll be looking at the lecture again, Interpretation of Retina Optical Coherence Tomography Angiography, which is called OCT Angio. Thank you very much for joining us once more. Dr. Odenrilo, over to you. Thank you. We can't hear you, sir. Please unmute yourself.
Okay, I have. IT is helping me today because the last lecture, please share the links. It's like the last lecture, many people could not see my course also. A lot of things I was explaining, some people couldn't get it. So I'm calling for IT support this time. One slide back. Okay, thank you. Okay, so good morning, everybody. Thank you for spending your morning with me. So briefly, we go through optical coherence tomography and angiography, OCTA. It's one of the it's a new investigational tool in
Hello, sir. We can't hear you, sir. Your mic is muted, sir.
Okay, next slide. How do I go to the next slide? Are you hearing me now?
Yes.
I just click on top of it. Okay. Okay, can you hear me now? Can you hear me now?
Yes.
Francis? Okay.
Yes.
Yeah, so not to waste too much time, we'll be talking about optical coherence tomography and angiography. My disclosure, I have no financial interest. Information for this presentation is from different sources, including our daily clinic rounds, our patients, different webinars, word rounds, and even published and unpublished articles. I will quote the people I'm talking about. So another word of caution, OCT and OCTA is meant to be used as an investigational tool. We don't treat OCT angiography scans, we treat patients. So you need to make sure you take an adequate history. There are a lot of things that may look very much alike. And so you need to do proper examination and confirm with other ancillary investigations so that patients can be treated well. So the last time we spoke about OCT, and I've really gotten a lot of questions around OCT, and OCT is an investigational tool that has come to stay. And all ophthalmologists basically should be aware and should know how to interpret OCT scans. Again, I need to say that this is just interpretation. I'm not going to be talking about how to take good quality OCT angiography scans. I'm not going to be talking about how to position your patients and many of those basic things, which sometimes I'm sure the academy will find time to talk about that. But today I'm going to concentrate on interpreting the OCT angiography angiographs. So the present challenges, what we look for now in OCT, we've seen a lot of structure. Now we are trying to look for function. We are trying to look at more of the details of the retinal vascular network. We are trying to look more of the details of the vitreoretinal junction. And as good as the OCT is, the imaging of the vitreous is not as much as many people would want. And also the imaging of the choroid and deeper structures. We need to improve a lot of that. And of course, we need to look at blood flow dynamics. It's because of these challenges that OCTA has come to be. OCTA has come to answer some of those questions. And it was first introduced in 2014. Of course, most time domain OCT came in 2002, and the spectral domain in 2006. Now, what OCT angiography adds to what we have now is function. OCT alone gives us structural images. So we can see the anatomy as excellent as we have never seen before without having to do any invasive thing to the patient. But what angiography adds to it now is a little bit more of function. We are able to see blood flow characteristics in the OCT angiography. So we remember OCT, we look at the structures, all the 10 layers, how we can identify them on the OCT. We covered that at the last lecture on OCT. So again, let me emphasize that there are new new definitions of terminologies to use in OCT, and those terminologies now, instead of the ISOS junction, it is the ellipsoid zone, and the interdepitating zone and others have now been introduced after the Committee on Terminology published their reports. So let's talk about the OCT angiography technology. I'm going to be basically talking more of the technology as it's presented on the OptoView, because I'm very familiar with the OptoView OCT angiography. That is not to say that it is the only one. There are many other OCT angiography with fantastic view and good technology. The HRT has good technology. I know the Topcon has the SS OCT, which is also extremely good, and it's very gives us detailed view of both structure and function of the retina. But I'm not used to the OptoView technology, so a lot of the things I'm going to say today will be around the OptoView technology. So basically, the Angioview, as it's called, incorporates 4 essential technologies in bringing out the image of the blood flow in the retina. The first is the SADA technology, which is an algorithm that is patented to OptoView. The full meaning of SADA is split spectrum amplitude decorrelation angiography. And it's usually just what basic technology it is that it's like you are taking the photograph of a moving object, and you know within the blood vessels, the red blood cells are moving. And it's, let me use the example of someone running, and you take his picture as he takes every step, and you know there will be a difference in each of the steps that he takes. And then you try and match those ones into a single image, now picking out the place where there is flow, the place where there is change. That flow is characterized by change in the position of the red blood cells. And so it's a proprietary algorithm is used to detect motion in vessels. It acquires serial OCT scans, and it's able to present it in an image that is easily analyzed. Now, the second thing it does, the technology, is that like every other OCT angiography technology, the presentation of the images are en face. And what that means is that it's taking a section, you are looking at the eye, and it's taking an en face section, you are looking at it directly. It's different from the images that are taken by the OCT alone, which are cross-sectional images, whereas the OCT angiography, it does en-face imaging. And en-face imaging helps us to establish a completely new anatomy to the retina, and we're able to see more. The third technology that is infused here is what is called the MCT, the motion correlation technology. One of the challenges we also had with the earlier OCTs was motion artifacts. And so this has a motion correction technology, which is actually done as a part of the post-scan processing, which means that you don't need to take the image again. After the image is taken and as it is being processed, the motion artifacts are removed. And this is really very helpful. And also we have the CUDA parallel computer platform, which dramatically reduces the computation time needed to process images and corrects motion artifacts after scan acquisition, making it easy to integrate into the OCT angiogram. Now, this 4 technology, they really do a lot of changes. It now helps us that one is able to quickly acquire images, motion artifacts are easily removed, and a better image that is more reproducible is produced. So also, one of the challenges we had with the OCT, with the basic OCT, the 3rd generation Fourier domain, was that most of them were located just within the posterior pole. Most of the scans were either 6x6 or 3x3 millimeter cubic scans, which focus mostly either on the macula or on the optic nerve head. But now, with this new OCT angiography, there are wider view OCT angiographies that can take beyond the posterior pole. And one can actually also do an OCT angio montage that helps to see a lot more of the image to the periphery than we used to. So let's look at the anatomy of the OCT angiography. It's important that we understand this. So for a long time, it's been known that there is not only one vascular plexus in the retina. In fact, it is postulated that there are three basic vascular plexi in the retina. The first is the superficial vascular plexus, the intermediate, and the deep vascular plexus. What the OCT angiography helps us to see is to be able to image the superior and the deep vascular plexus as different from other structures, and it brings out the image and presents it to us, so we're able to analyze both these layers. Now, the superficial plexus is usually between the ILM and the IPL, whereas the deep plexus is between the INL and the OPL. Of course, I'm sure you know my abbreviations are inner nuclear layer and the outer plexiform layer. The other thing we're able to see is the outer retinal zone, which is the area of the RPE, and don't forget the RPE is avascular, and so that image to appear dark. If there are vessels coming up here, then it means that choroidal neovascular membranes are breaking through the RPE. So this should be dark. There shouldn't be any images there. And of course, the speckled appearance of the choroid shows us that it is a highly vascular structure. So we have these four images show up on OCT angiography. We've never seen the retina with such detail before. So in a normal planes on the OCT angiography, you are going to see a print of the superficial vascular plexus, the deep vascular plexus, the outer retina, and the choriocapillaries. And also you can see the angio images superimposed on the SLO fundus images. And because these images are acquired from a basic OCT scan, you can also see the cross-sectional OCT image beside it. So let's go and look at how does this help us now in retina. Why do we go to this much detail? For instance, we look at diabetic mellitus, which is the leading cause of visual impairment in the working age adults in the US. About 25.6 million over the age of 20 have diabetes, and that is given about a prevalence rate of individuals, a 30% prevalence rate in individuals over the age of 40. So type 1, type 2, we all know the likely complications that they can bring. So in the macula, we are all very familiar with the classification of diabetic retinopathy, and we know the non-proliferative and the proliferative stages, and we know the severe non-proliferative in between. Now, this particularly, a lot of things is going on in the macula. If you are looking at cross-sectional images of only OCT, you get a lot of information on edema, swelling. That is how much swelling, how much fluid do we have in the macula. We can see the cystic hyporeflective lesions within the inner retina, and we can see the thickness of the retina on OCT maps. The OCT angiography helps us to further classify and to further view the details of the fovea. It helps us to be able to assess the fovea avascular zone and the vascular density in the area of the fovea, as we've not been able to do before. And previous studies, what has been done for a long time is to use fluorescein angiography. And you know, for fluorescein angiography, you have to inject a dye. A lot of people now shy away from that. We are doing less fluorescein angiography injections. I'm not saying we are not doing it again. I'm saying we are doing less, because OCT angiography is able to give us even more detail of the fovea avascular zone and the vascular density, much more than the fluorescein angiography can give us. I also want to tell us that the fluorescein angiography only images the superficial vascular plexus. It doesn't image the deep vascular plexus well. So, and again, because the patterns that we look at on the angiography, hypo and hyperfluorescence, where there's hyperfluorescence and leakage, it may obscure underlying details. And currently, we can look at there are now fluorescent angiography images that can do wide field and look more to the periphery, just like we have the OCT. But the OCTA provides a snapshot of the vascular integrity around the macula and even beyond with the montage. It's much safer and quicker to perform. You don't have to inject a dye. There are a lot of things that go along with dye injection. You have to have a resuscitation around. You have to be ready to in case somebody has a reaction, an anaphylactic or idiosyncratic to the dye that is being injected. So this really helps us a lot of, we can take quick images of the retina without having to inject a dye, and even technicians, well-trained technicians can do it. If we are doing FFA, we have to get a doctor to stay beside the patient and the technician in order to forestall for any complications. But with the OCTA, you don't need to inject a dye. You really don't need to keep oxygen around as we normally would do. So we see in the OCTA the different pathologies from different layers in diabetic retinopathy. We can see the superficial, we can see an enlarged fovea avascular zone here. We can see the deep vascular plexus. We can also see that there's an enlarged fovea avascular zone. We can see the outer, and we can see the choriocapillary as well. Now, on the Angio, on the OCT Octaview, the Angio analytics software is also able to give us some more detail. We're able actually to measure the fovea avascular zone. In the earlier options that there were on most of the OCT angiography, you actually have to put the calipers there yourself to measure the OCT, to measure the fovea avascular zone. But now, with the new Angio analytics software, it automatically measures the fovea avascular zone for you. That is so important, especially for a lot of people doing studies. Our concern when we do such studies is if we are taking the exact position, because human nature, someone can put his caliper a little bit further than it should be, and then the measurements may not be ideal. But with the software evaluation, it makes it more reproducible. And also, we can track the changes of the fovea avascular zone over a period of time. We can put the values as it's represented here. Look at this patient 2015, 2016, 2017, and we can see how this goes. I also need to emphasize, because why are we looking at the fovea avascular zone? Because it's been established that patients with DM, they are more likely to have a larger fovea avascular zone than healthy eyes. And these fovea avascular zone changes occur long before we start seeing any visible fundoscopy signs, before we start seeing microaneurysms, before we start seeing. So it's the earliest way now that one can begin to assess a patient and to monitor the patient closely. And also, not only does it different, is it different between the non-proliferate, between the diabetic retinopathy and the normal patients. Also, within each of the stages of diabetic retinopathy, fovea avascular zone sizes are different. With the proliferative, you have a much larger one, and this is a study that shows us the average, and those with the mild. The FAZ tends to enlarge as we progress along the classification to the worst ones. Now, not only that, we can also measure the vascular density. There are the vascular density maps. The vascular density maps help us to look at the vascular density around the fovea for both the superficial and the deep plexus. We can also look at the radial capillary slab. This is important in glaucoma, and we're able to analyze how much the blood flow around the head of the optic nerve head, and it's been found that those patients with glaucoma tend to have a lower capillary network vasculature than the normal patient. So this helps us to capture a lot of information before they start causing trouble, and we can actually see. The vascular density map also has analysis that we can actually look this vascular density within this fovea is 43.4% and about 46.3% around the deep ear. So we can subsequently follow these patients, and we can look at patients who are likely. Sometimes some of our patients will complain in diabetic retinopathy of a slight blurring in vision, and you don't know why. You've done every other thing. You've done the fundus photograph. You've even done the OCT, normal contours, normal fovea depression. With an OCT angiography, you can actually get a lot more information to see what is going on in the area of the fovea. And you can also get trend maps for the vascular density that will let you see as it goes. Just like the fovea vascular zone, it's also been established that where fovea vascular density changes in diabetic retinopathy patients. And when you compare to normal, the fovea density begins to reduce. And when it's going to be proliferative, it's really much, much lower than in the normal patients. So we can also look at non-flow area characteristics. We can look at areas where there are good flow. This is good in patients who have, for instance, vein occlusions. You can look at areas where there's good blood flow and areas where the blood flow is inadequate. This is something I also like to do. It has a quick report, and on the quick report, it gives us a number of things that we can just look at a glance. Of course, we can look at superficial deep vascular plexus. We can look at the outer retina and the choriocapillaries. This is the vessel overlay. This is the vascular overlay. These red areas are areas where there is significantly higher blood flow. Of course, this is the cross-sectional OCT image. This is the vessel density. And you have all these details on a single information. Yeah, so this is one of our patients. You can see diabetic, non-proliferative, but you can actually see that it's beginning to have an enlargement in the fovea vascular zone for both the superficial and the deep. It still has good vessel perfusion, but this is a patient we watch out for. Look at the vessel density, FAZ, vessel density, and you can see these capillary dropouts here much earlier before the patient even begins to complain too much. Again, retinal vein occlusions. One of the problems, like I said before, is the masking effect that we see when there is pooling of dye when we are assessing for vein occlusion. So we see this diffuse leakage, what you don't see on OCT angiography. So we are able to actually outline the vessels more. You see the areas of capillary dropouts. These are important because in the earlier studies, this BRV and CRVO studies, they evaluated the percentage of capillary non-perfusion, and it was used to classify RVOs into ischemic and non-ischemic RVOs. And so for them, we used to actually wait until the hemorrhages clear very well before we can get very good images of the fovea. But with this, with the OCT angiography at earlier periods, although yes, with heavy plane-shaped hemorrhages could still obstruct a number of structures, but earlier than the FA can pick it, the OCTA can pick those changes. And I'm sure that within the next few years, we'll be able to further define exactly how much ischemia we see on OCTA and how we can use to classify the images into, the disorders into ischemic and non-ischemic, and there are two contributions. Again, you can see even in a normal FFA, when you compare it to the OCTA, you can see a lot more detailed areas of ischemia, vascular congestion. You can see better than you will see with the FFA. So I'll introduce us to something else that comes up to us with the introduction of the OCT angiography. Like I said, it's been postulated that there are three basic layers of the retinal vascular network: the superficial, the deep, and the intermediate. So paracentral acute middle maculopathy is a spectral domain optical coherence tomography finding. Was first reported in 2013 and is interpreted as a possible more superficial variant of acute macular neuroretinopathy. It is characterized by hyperreflective bands and multiple isolated focal and diffuse lesions visible at the level of the inner nuclear layer in patients presenting with acute onset of negative scotomas. It is termed PAM due to the parafoveal position of the causative gray lesions with near-infrared reflectance imaging and the OCT localization of the involvement of the middle layer of the retina. So sometimes with clinical features, it's based on patient's history, fundoscopy. PAM lesions appear as subtle whitish parafoveal lesions deeper within the retina with a smoother contour and grayer than cottonwood spots. They are a strong differential of cottonwood spots, but they definitely look different. This is a presentation of a case report of a patient with PAM, and you can see the image. You see how it looks. This whitish area, which you see on the front on the fundus picture. Note the fluorescein angiography. You do not see that. Like I told you, fluorescein angiography will only image superficial vascular plexus. So you don't see anything. And you probably think there's not, I mean, what does this mean? And so, but on OCT angiography, you are able to see at the deep, you are able to see the area of vascular capillary loss. And these are SLO images also that can tell us the changes. So that's our patients, and after management, you can see that it clears out. So that's one of our presentation. There's focal vascular remodeling with pruning of the intermediate and posterior capillary plexus over a period of time. So we can also on the OCT angiography look at flow characteristics, like I said, especially when we are looking at the posterior, the outer retina. You can look at the choroidal neovascular membranes. And don't let's forget there are 4 different types: type 1, occult; type 2, classic; type 3, retinal angiomatous proliferation; type 4. And we can see that very well on the OCT angiography. You can see this more commonly in the type 1, which is below the RP. You can see these 2 areas are clear, but definitely you see this in the choroidal slab, which goes above the RP. It begins to show up in the area of the RP. And this is a patient of ours with type 2. Of course, you see superficial, deep, clear, but you see the choroidal neovascular membrane here, which has already broken through the RP. This is you superimpose a outer or inner retina image of the vascular plexus onto the fundus photograph, and you can see there, and you see these changes. So also you can do a segmentation and look at different images very differently. You can measure the area of flow. You can measure how much the area of flow. There's a study by Harakong that it just helps us to be able to describe the different morphological patterns. This it hasn't passed through any standardized committee meeting, but I like to use this because of my one has to write reports. And so how do you really describe how the choroidal neovascular membrane looks like? So it's a C-fan-like. That's when the membrane is radiated. It's like half the medusa, when the vessels are scattered all around, the ill-defined one, and the long filamentous one. So My chiefs are here. I need to see those terminologies when you are describing an OCT. You need to tell me. And so also don't forget that I can form fibrous scars, and choroidal neovascular membranes can happen from other sources, from myopic choroidal neovascular membrane. This is the filamentous one we talk about. Very importantly, we have to evaluate if that choroidal neovascular membrane is active or is inactive. I'll talk about that, and then we look at it. So that is for the basics. Now, when you are interpreting outer retina disorders, I suggest that we should follow a certain, just something to help to guide us to how do we approach the interpretation of outer retina. First of all, of course, you know normal vasculature, you know how it should look like. Second, we need to evaluate the fundus picture, the OCT B scans, and outer retina slabs. Very important. It is good that one really has a look at the fundus picture, not just, that's why at the disclaimer I say we don't treat scans, we treat patients. Look, first of all, take a history. If the patient is myopic, then you are thinking more of a myopic choroidal neovascular membrane. So these things are good to look. And number two is to look at a Bscan and the flow overlay. The flow overlay is very important. These red areas show us, they show areas where there's high flow. Now there's no choroidal neovascular membrane here, and you can't see any high flow there. There's a choroidal neovascular membrane here. You can see the high flow. So that's very important to know. If I will also show us an example, you can see this. There's a high flow here. You can see this high flow. This is like a Mendoza pattern. And also step 3, look for false negatives. False negatives are things that can mimic. There's a choroidal neovascular membrane, but things are covering it. And one of it is shadowing. Inner retinal lesions can cause shadowing, like exudates, they can cause shadowing where there's a choroidal neovascular membrane and you may not see it. So look out for that. And also look out for false positives. That is, there is no choroidal neovascular membrane, but there's something that wants to mimic it. And one of the common things is geographic atrophy. That area is atrophic, so there's an enhanced visibility of the retinal vessels because of the geographic atrophy, not because there's a choroidal neovascular membrane. The second one is projection artifacts, where an inner retinal vessel is projected into the deep retinal vessel to give a false appearance of a choroidal neovascular membrane. So this is a patient of mine. She's had three intravitreal injections for myopic choroidal neovascular membrane. She doesn't have metamorphopsia. Her vision is 6/9. She's happy. She's a high myope. She's had LASIK, so she has a 6/9 vision. She's happy. She comes in, no complaints, and I see this. So I'm asking myself, is this a choroidal neovascular membrane coming up, or is it just a scar from my previous treatment? So you do an OCTA, and you're able to see the vessels, they're okay, the choroid is okay, there's this central area, then you do a vascular overlay. If you look at this area, there's no increased vascularization. This is a scar. If it's a choroidal neovascular membrane, you see increased vascularization. So I'm happy to be able to monitor her conservatively rather than sticking my needle there again. And so there are other appearances that we can have, and other from CSR, all other things that we can see clearer on the OCT angiography that we do not see. Like for instance, this patient, when you see there's some subretinal fluid, but both there's a hot spot, and you can see this area there, but definitely the OCT angiography shows you the choroidal neovascular membrane, and you can begin to plan to treat it. So in summary, OCT angiography is a new investigative tool for retina. It shows a lot of promise for evaluation in retinal vascular changes without having to use a dye. It's rapid, it's non-invasive, it's reproducible, and it's accurate. So these factors make it a very important diagnostic tool for every ophthalmologist to fully understand. And gradually, more and more of OCT and Angiography is coming into our clinic, and we need to be on top of our game. So thank you for listening. This time I've tried to keep to the time I was given, and I'm finishing 8:45 as I was told by Madam Frances to finish. Thank you, everybody. Thank you for listening. We'll now take questions. Thank you.
Thank you very much, sir, for this interesting lecture. I'm not a medical person, but it seems all very, very interesting. Thank you, sir, for your time. The floor is now open for questions. You can either raise your hand up or unmute your mic to ask your questions, or type your questions in the chat box. Thank you.
So it's either nobody understood me at all, or it was very explicit.
Good morning. I have a question.
Yes, please, go ahead.
Thank you very much, Dr. Odenilo. This your presentation was really good and a very nice eye-opener. We appreciate your attempt, yes, to educate us. My question is about widening of the fovea avascular zone in diabetes. When
Yes,
we find this out with OCT, apart from counseling and ensuring they have good blood sugar control, what else will you do at that stage? For example, if the patient has not developed obvious retinopathy, maculopathy.
Okay, thank you, Matt. So again, the OCT angiography is just new. So studies are still going on about the exact implication of these changes that are seen. But right now, what it helps us to do is for better monitoring and for advice for stricter control. So that, possibly if I saw a patient, normally without OCT angiography, we classify it as no diabetic retinopathy, and I might say, see me in 9 months. But if I see fovea avascular zone changes, I'm going to write the physician to let them know that I'm going to do some functional changes so the patient can ensure better control, and also other risk factors, systemic hypertension, lipidemia, and so it helps us to manage these patients strictly. So the patient, I won't be given 9 months or so to come back. I will see him closer, I will monitor him closer. At least I will sound like a sensible person when I write a letter to his endocrinologist why I'm requesting a stricter control. But with time, we will be able to really identify if we should start a sort of classification with fovea avascular zone for the diabetic maculopathy, and then the implications. But really a lot of studies are going on that. But for now, that's what it helps us to do. It's not an indication for active EGF, it's not an indication for laser, it's not just an indication for stricter control of the diabetes and other systemic risk factors. And better,
thank you very much.
Yes, ma'am.
What of sickle cell patients? Is there a role OCT plays for the OCT angio plays in their management as well? When you mentioned CFAN distribution, I just remembered sickle cell patients.
Okay, ma. So you are really taking.
Their lesions are peripheral.
Yes, you are taking words out of my mouth because we are presently doing a study to find out the fovea avascular zone changes in sickle cell retinopathy. And so we initially had a study on vitreoretinal interface disorders in sickle cell, and we found out that even before they start having those CFANs, they are beginning to have changes in their macula. So we are now doing fovea avascular zone assessment and vessel density assessment in sickle cell retinopathy. We've not finished our study, but we are actually seeing changes in the center. Even at Goldberg stage 2, we are beginning to see that there are fovea avascular zone changes and vessel density changes in these patients, even before they develop CFANs. Like I said, OCT Angio is new to us, but once we're able to define this, it will help us to know, how to closely monitor patients and probably help be an indication for treatment earlier on. Again, as a follow-up on that, once we're able to establish that, we also need to look at what is the effect of doing laser photocoagulation for CFANs in the periphery. What's the effect on the fovea, the avascular zone, and the vessel density? So there are a lot of questions to answer, and the use of the OCT angiography really opens up a lot more that we need to know about our patients to be able to manage them better.
Thank you. Is your Angio at Ikeja or Lekki?
Both, ma'am.
So thanks so much. So we know where to refer our patients.
Thank you, ma'am.
Thank you so much.
Thank you so much. We have a question typed in the chat box. I don't know if it's the one we've already answered. He said, please, is there any place for AI? I'm assuming AI might be artificial intelligence. Please correct me, sir. Please, is there any place for AI in OCTA interpretation yet?
Yes. So again, a lot of studies are going on with AI for OCT angiography. It's a very good tool and something that is quite amenable to artificial intelligence. Unfortunately, I don't have any confirmed, well-established study to quote. I only know studies now that are registered on the trials, clinicaltrials.gov, which you have to register a study. And yes, there are AI studies about OCT angiography, but outcomes are still a little bit fuzzy. But like I said, in the next 2-3 years, we have a lot of information. This is a very amenable tool for OCT, for AI, because it's an image that's an AI, especially the vessel density. AI can really be taught to classify it and to give them prognostic indications for the outcomes.
Thank you, sir. There's another question that says, does the OCTA help in the retinal vascular occlusive disorder?
Yes, so if you say occlusive disorder, vein occlusions, yes, I mentioned some of them, and arterial occlusions too. Yes, it helps us to really know what is going on. Yeah, it does help. And I mentioned for CRV and PRV. Yeah.
Okay, do we have any more questions? Any more questions or comments or addition?
Yes, please. How soon will this recording be available on YouTube?
In the next 1 week, ma'am, it will be up.
Thank you so much.
Yes, ma'am.
Okay, so I can see a question here from Abayomi Oluwa Timileyin Bamidele. It says, to what extent in your experience does intraoperative OCT help in retina surgery? Okay, so we don't have intraretinal OCT, intraoperative OCT. It comes with the Lumera 700 and it has almost $150,000 additional to the cost of your Lumera. However, I think it's a very important tool, and from what I've studied about it, for instance, when you are operating the macula, that's really when it is important. Yesterday, we did a surgery of a patient with a partial thickness macular hole. If I had an intraoperative OCT, it will help me to be able to really gauge how deep the fovea is and how, because usually now I do an inverted flap technique. So it helps me to be able to know how deep, and I'll be able to know how much I can torque the ILM into it, but I couldn't really assess it well. So I did the traditional 360-degree ILM peel, the donuts technique is what I had to do yesterday. But sincerely, if I had an intraoperative OCT, it will help me better. And for full thickness macular holes, you see, especially when we're inverting flaps, sometimes we tend to overstuff the hole because we don't want it to fail. So we stuff it. But if I had an intraoperative OCT, I can really assess how much. And if you look at macular holes, you know, they have different morphologies. Some of them have very undermined edges. And so that really helps you to make sure that you can fill the holes well. So yes, it's very important, very helpful. Well, what do we do when my people will say, money said that you shouldn't talk when he's not around? So what do we do? We only wish we can get it, but it's very useful.
Thank you very much, Dr. Adarila. This is outside our present scope, but I think it can be useful. I just became aware of what we call an exoscope. It's a 3D camera used by neurosurgeons. Ophthalmologists are beginning to use it as well. It helps us to see our field of surgery in 3D, and is very good for microvascular procedures. So I don't know, because like you were operating on the macula, if you have an endoscope, I'm sure it would have helped.
Okay, man. So they use endoscopes a lot in retinal surgery, man.
Yeah. Oh, okay. Do you have people here?
Yes, ma'am. So we don't have endoscopes, but they use them a lot in retina. Sorry?
Exoscope. EX.
ES.
Yes.
Exoscopes. Okay.
Exoscope.
Oh, then I would like to know more about that, man. I thought you said endo.
No. Exo helps us to see in 3 dimensions. Very good for microvascular procedures.
Okay, but are you talking about heads-up surgery where you see in 3D?
Yes.
Oh, yes, that's also very available, especially it's being marketed by Alcon. Again, we don't have, so I don't have any personal experience with it, but of course, I've attended a lot of seminars.
I was very excited. I got this topic to give to medical students, and I said, what is an exoscope? I went online, I went on YouTube and saw it, and oh.
Wow. You can buy one for me, man.
Let's try it now. Thank you so much.
Okay, man.
Any more questions? Our time is almost up. Any more questions before we wrap up? Okay, in the absence of no more questions, I would like to thank everyone once again for joining us. This Vitreoretina series is anchored by the Kunle Hassan Eye Foundation Academy. You can go on there to see most of the lectures on our YouTube page. We also do the founder series. You can also go on there. We hope to keep this Vitreoretina series on at least once every month. The next date chosen will be publicized. Once again, I say thank you, Dr. Derilo, for taking the time to deliver this lecture. Thank you very much, sir. And thank you everyone for joining. Thank you.